Hello, my name is Clyde Yancy. I am Chief of Cardiology at Northwestern University Feinberg School of Medicine, and I'm here with my good friend and colleague, Dr. Gregg Fonarow, who's the Clinical Chief of Cardiology at UCLA Medical Center in Los Angeles, California. Greg and I just finished serving on a panel as discussants for a very interesting session here at American Heart Association scientific sessions called Off the Beaten Pathologies. Greg, it really was a really interesting session.
4 very interesting trials presented, one of which is certainly going to be practice changing.
Absolutely. So let's just get right to it. There were 4 sets of data points that were presented. Both of us served as discussants. But the entirety of this, and I thought it was actually a novel nomenclature, these really were very different approaches to deal with heart failure. So you actually dealt with the very first set of data, another data analysis or set of analyses from the phenomenal Paradigm-HF study. Why don't you tell us briefly what you saw and what your thoughts were?
So this presentation really built upon the analyses that have already been presented and published. So the primary endpoint, this robust reduction in cardiovascular death and heart failure hospitalizations that we're seeing. But then building upon that, looking at a variety of endpoints that really reflect is LZZ 696 added to standard care, up and above what could be achieved with an ACE inhibitor ARB, really halting disease progression. And we saw endpoints such as emergency department visits, all-cause hospitalization being robustly reduced. When the patient was hospitalized, less likely to be in ICU, shorter days in the ICU, less worsening of heart failure. So really very consistent findings with regards to altering the natural history of heart failure. So really building upon those primary endpoints and really reinforcing here with this single trial, we really have something that can change the course of outcomes for our patients with heart failure in a meaningful way.
Kind of the slam dunk of clinical trials once you saw the preponderance of information. But there were some important questions that came out during the additional discussion. I thought one of the questions that was especially relevant had to do with the necessity for durable blood pressure, because I think as we're starting to export this treatment to the rest of the community, these kinds of observations I think will be important.
Yeah, absolutely. It's really important to recognize these were patients that had to have systolic blood pressures of 95 and were actually in that run-in phase, tolerated really good doses of ACE inhibitors. So it was brought up in the discussion, what about these patients that have lower blood pressures, are barely tolerating very low dose ACE inhibitor ARB? Are they going to be candidates for LZZ 696? And the discussion was, we're really going to need additional data there. And likewise, certain populations that were not well studied, you raised the excellent point about African American patients. We know from prior studies there was more angioedema in that group with an agent that combined neurolepsin inhibitor with an ACE inhibitor, omapatrolat. So the safety there. So additional data is going to need to be forthcoming, but certainly for that core group that was studied in this trial, we really have robust findings.
So that was a big story in Off the Beaten Pathologies. Now the other big story was yet another effort at using stem cells to treat post-MI LV dysfunction. A great effort, very nicely, almost expertly executed, but with, again, soft endpoints. And this is really going to become our holy grail. But I applaud the investigators for trying using CD34 positive cells derived from bone marrow to see if that would make a difference. In yet another provocative set of studies, there was a spinal cord stimulation study done to see if you could modify autonomic tone. What did you think about that?
So really intriguing, so we use our ACE inhibitors and our ARBs and think maybe they're augmenting parasympathetic tone and altering sympathetic tone. Certainly our beta blockers, but what about this direct spinal stimulation? Certainly Dr. Zipes had presented this kind of compelling preclinical data in animal models on top of medical therapy, something rarely done in animal models, and showing this real improvement in LV function. So they took that on through, building on spinal stimulation as a treatment for angina, and executed a good trial. The challenge, of course, was for their primary and secondary outcomes, they really did not see any improvement. So it raises that question, is it the wrong concept that spinal stimulation could really alter the neuromodulation in a way directly to the heart, or was it just the execution that it's the right hypothesis, but the way they set it up, only 12 hours a day, single lead, was that really sufficient?
And I thought the discussant, Dr. Udelson, really made an excellent point. Of 4 studies that have been done, a 5th one ongoing, the 2 that were unblinded had these favorable suggestive responses, but the 2 that were more rigorously performed that seemed to manage the placebo effect, you didn't see it, so maybe it's another lesson learned. Finally, we saw this very provocative, intriguing, almost amazing concept of injecting an inert material into the wall of the left ventricle to attempt to modify the Laplace relationship, reduce wall stress, if you will, artifactually, and see if that would in fact lead to an improvement in some surrogate of ventricular performance or clinical benefit. And wow, we did see an improvement in exercise capacity that was non-trivial. But it's the beginning of a very long journey, and it will be very interesting to understand more about the biology. I think overall it was a fascinating session because we went way beyond the usual approaches to treat heart failure and looked at some novel devices, some novel pathophysiology approaches, and we saw some more evidence of this really incredibly important new paradigm to treat heart failure. Any final statement you want to make about this off-the-beaten pathologies?
Yeah, well, one of the things that was so striking was the discussion, if you think about trying to alter wall stress, how much there has been invested over 25 years. If you think back to dynamic cardiomyoplasty, that was kind of the theory.
Right.
And some of these ventricular kind of girdling devices thought about, and even the surgical restoration of the ventricle. So we've really been on this theme, but there's been some of the advances of trying to make this a little less invasive, and we'd even hope that you could find a way of doing even this testing without having to open the chest. So I think why these novel concepts continue to evolve, we're seeing as technology evolves, we may finally be able to get there where we have the breakthrough. Certainly with LZZ 696, we are there.
Great. So once again, incredible science at the American Heart Association Scientific Sessions. You're listening to AHA Science News from Chicago, American Heart Association Scientific Sessions 2014, bringing you up-to-date breaking news on emerging clinical science from off-the-beaten pathologies. Thanks for listening to us.